Hey, welcome back. In this video, we're going to talk about admissions and discharge in the emergency room. So we've been doing a mini series about the entire emergency room process. The first two videos were about the initial triage of your patient and then also your assessment. So if you missed those two videos, go back, watch those ones first, and then come back. All right, let's get started talking about admissions. So at this point, the patient has already been assessed. The doctor has already examined them. They've put in orders. You've run tests. You've probably done labs, urine. Depending on what they're there for, you might have done an EKG, imaging, x-ray, whatever it is. You've already kind of compiled the information you need. And this is sort of the decision point where the emergency room physicians are going to look at all the data, probably talk to the hospitalist, and then recommend that either this patient is sick enough or unstable enough that they need to be admitted to a floor, or if they could be treated at home or outpatient somewhere else, outpatient surgery or whatever, then they would put in discharge orders. So a patient that is going to be admitted, obviously they're going to be maybe unstable and hemodynamically unstable. Maybe they need medications called vasopressors to keep their blood pressure at an appropriate place. Or if they cannot breathe on their own, they're going to need oxygen, ventilation, anything like that. Obviously, they're going to be admitted to the ICU, where they can be monitored and treated. Another thing you're going to see all the time is infection-related disease. So pneumonia is something you're going to see quite often. That can occur at any age group, but especially older folks, if they're not as mobile as they used to be, or they're lying in bed more, they're going to be at a higher risk of getting pneumonia. Skin infection, hopefully you catch anything early if they're going into septic shock or sepsis. So any kind of infection like that, they're probably going to be admitted to the floor so that they can receive IV antibiotics. Other things that would be reason to admit a patient would be strokes, heart attacks, anything that they're going to need some continuous treatment and observation after the fact. If they have to go to the cath lab, or if they have to get TPA to break down those clots. If it's a ischemic stroke, they might have to have a clot retrieval. So those are patients that are going to need admission. And other things you might see is like serious electrolyte imbalances and dehydration, if they're going to need a lot of fluid resuscitation. Also like DKA, diabetic ketoacidosis, they might need insulin management, and just making sure that that is under control before they are discharged to go home. Patients could show up with acute abdominal pain and nausea, and upon assessment you realize, oh, there's appendicitis going on here, or they have a major inflamed gallbladder and they're going to actually require surgery. They might be admitted so that they can get that surgery knocked out, and then they might be in the hospital for just like a day of observation after that. And similar diagnosis is not going to be treated the same among all populations. If you have a 20-year-old with a UTI, that's going to be most likely treated a lot differently than an elderly person with a UTI, with a history of UTIs, and they present into the ER with altered mental status and they don't even know where they are. That person might actually need to be admitted, versus the young person who's just like, yeah, it burns when I pee. Okay, you can go home with this prescription for antibiotics. Follow up if it doesn't get better. So if they do meet admission criteria, make sure that you have completed all the orders that were put in during your time. You don't want to send that up to the floor. Don't be rude. And you want to make sure the patient is in a gown, that they have adequate IV access so that the floor doesn't have to worry about that, especially if they're going to the ICU. I think it's a pretty common criteria that your patient has at least 2 IV access points. And you want to make sure you understand the history, the condition, so that you can give a effective and clear report to the floor. And as soon as the bed's ready, you call report and you make sure that they get up there safely so that you can continue to manage your other patients that will keep pouring through the door. And then you have your discharge. Most of your patients will probably be discharged rather than admitted, depending on what kind of ER you work at. But if the physicians have determined that this patient is stable, or that they have some condition that can easily be treated at home or outpatient clinics, or maybe a outpatient surgery, then they will have some kind of system in place at your ER that will print out information that is specific to their condition, that will kind of help guide you with your discharge education and instructions. And also just having the experience of, okay, I've seen this kind of diagnosis 50 times. I know, generally what kind of education I need to give this particular patient. So if they are being prescribed an antibiotic for a localized infection they have, you're like, hey, make sure you pick up these prescriptions at the local pharmacy, and make sure you eat a little bit of food before you take those antibiotics because it can upset your stomach. Please take the full regimen of antibiotics even if you start feeling better. It is very important that you don't stop halfway through the prescription, because then you can develop resistance to antibiotics, and whatever's making you sick can come back in a even more evil form. And so that's just one specific example, but you're gonna start to learn the different kinds of diagnosis that you see frequently, and you'll be more confident in being able to give good discharge instructions and be able to point them in towards the resources that we're providing. Like, hey, make sure you follow up with your cardiologist. You probably need to get on a blood pressure medication. Your blood pressure was a little bit high. We're not judging, but please follow up with your doctor. The emergency room is a specialty in itself. There's a lot of chronic conditions that we're not really going to be able to fix the underlying problem in the ER. We can make sure that you're not dying, that you're stable, and if you're not, we'll admit you. And if you are, we might be able to treat your pain or kind of help provide a couple of answers. But a lot of times you're going to be referring people out to other specialties. If someone comes in with a simple laceration, we have to give them stitches. That's an easy discharge. They just need to go home, keep it dry and clean, and come back in 7 to 10 days to have the sutures removed. Or maybe a woman comes in who's pregnant and has been vomiting and she can't get that under control. All right, we'll treat the nausea, we'll give her fluids, make sure she is not dehydrated, and then probably that's also going to be a discharge. There's not a whole lot more we can do except refer you to your OB and say, hey, return if you still can't keep this under control. So things like that will kind of give you temporary fixes, but if it's like a chronic issue, that is something that is going to be outpatient, and we're limited as far as being able to fix big issues like that. All right, so that wraps up this little series about the ER process. I hope you learned some stuff about that, how it works in the ER as a nurse. And if you enjoyed this video or learned anything, please subscribe, like this video, share it, and if you have any questions, just drop them in the comment section below. All right, thank you.